All right, let's just stay where it's at. Talking about atrial fibrillation. Let me grab my call. Okay, so atrial fibrillation. The atria no longer contract, but instead fibrillate or quiver with no organized contraction. Nothing's really happening as far as work is happening. It's just sitting there spazzing out. Cells in the atria depolarize independently rather than in response to an SA node impulse. So whenever the heart beats, it's like an orchestra. Everything happens within a rhythm. Whenever fibrillation is happening, everything's doing its own whatever. Like the drums are off beat, the clarinets are playing clarinet sounds, the trumpets aren't even, they're asleep somewhere, maybe not even firing, who knows. Whatever's happening in this orchestra is completely chaotic and all over the place. This results in a chaotic baseline. It's characterized by no visible P waves on the EKG strip. There's no PRI to measure. Irregular appearances. QRS complex is still 0.11 seconds because this isn't happening in the atria, or this is happening in the atria, but everything happening in the ventricles is still happening normally. Common symptoms among older patients can have this. It increases your risks of stroke because blood within the fibrillating atria tends to clot. It's not going anywhere. It's stable, but symptomatic patients may be prescribed any sorts of warfarin, Coumadin, anticoagulant medication. They could also be given beta blockers or calcium channel blockers or digoxin. Digoxin comes from a digoxin plant. The unstable patient may need synchronized cardioversion, and pre-hospital treatment of AF is uncommon in stable patients. So we're not going to do a whole lot. Atrial flutter. Atrial impulses that fire at a rate too fast for the ventricles to keep up with. So atrial complexes are known as flutter waves or F waves, with a distinct sawtooth shape that is resembling a picket fence. One or more F wave could get blocked by the AV node, resulting in several F waves before each QRS complex. Usually regular with constant usual 2-to-1 ratio conduction, or irregular with QRS complex measuring 0.11 seconds or 110 milliseconds or less. So you can see the sawtooth method here. This is one of the easier waves to pick out. Now in some books or strips, when you're looking at them, they might be a lot less distinct and smaller than this. So you're going to have to decide between whether this is a flutter or a fib. NES can degenerate into AFib. Patients are often prescribed anticoagulant medications, and also they have the same risk of a thromboembolism as patients with AFib. A beta blocker, calcium channel blocker, can be administered if the patient is stable but symptomatic. Synchronized cardioversion may be necessary if the patient is unstable, and pre-hospital treatments are uncommon in stable patients. Then you have your wandering atrial pacemaker. This pacemaker moves from the SA node to various areas within the atria or the AV junction. The rate is usually 60 to 100 beats per minute with a slightly irregular rhythm, and R-to-R intervals are based on the pacemaker site for that particular complex. An upright P wave precedes each QRS complex. However, the P wave shapes may indicate multiple sites of origin. Definition requires the presence of at least 3 different shapes of P waves on one ECG strip. It's characterized by our PRI being 0.12 to 0.2 seconds, and the QRS is nice and tight at 0.11. If it's seen in children, it can be seen in children, older adults, and athletes. I wonder if that's... I don't know. My cardiologist saw something, and I'm not sure what it was, honestly. Treatment is indicated in the pre-hospital setting only if dysrhythmias, if the dysrhythmia is associated with a slow rate and the patient is symptomatic. So we're going to, treatment would be the same for symptomatic sinus bradycardia. I think my brain is starting to give out. I need more coffee. Multifocal atrial tachycardia, MAT. Multiple ectopic sites within the atria depolarize at different but rapid rates, characterized by a rate of more than 100 beats per minute. A tachycardic wandering atrial pacemaker with an irregular rhythm and an R-to-R interval that would vary based on the site of the pacemaker. There's an upright P wave that is preceding each QRS complex, but the P waves vary, indicating multiple sites of origin. So our PRI is 0.12 to 0.2 seconds still. QRS is nice and tight at 0.11. P waves may not be visible in the MAT due to increases more than 150 beats per minute, which we are not there yet. Let's see, 300, 100, right on the cusp of it, which is why you can still see it. Most often seen in patients with significant lung disease, pulmonary hypertension, coronary disease, valvular heart disease, hypomagnesia, and also seen in patients undergoing the theophylline therapy. Treatment is not usually at the pre-hospital level, and therapies for SVT generally are ineffective with MAT. For rhythms originating at the AV junction, we should take over if the SA node fails to initiate an impulse. So AV junction is our second line of defense. It is the 2 out of 3 pacemakers that you have intrinsically. Junctional rhythms normally have a rate of 40 to 60 beats per minute. An impulse generated by the AV junction travels down into the ventricles and up towards your SA node. This leads to 3 possible circumstances in which the QRS complex appears normal. If the impulse begins moving upward through the atria before the other part enters the ventricles, then there's an upside down P wave will show and followed immediately by the QRS complex. The impulse begins moving upward through the atria before the other part enters the ventricles. Interesting. If the impulse is moving through the atria occurs at the exact time that it travels through the ventricles, the smaller inverted P wave will be hidden within the QRS complex, giving the appearance of a missing P wave until a normal QRS complex begins. So, our QRS is going to be where most of the electricity is happening. Everyone's watching that, and it's eclipsed. It eclipses the P wave in this case. If the impulse starts late through the atria, it will result in an inverted P wave after the QRS complex. A premature junctional complex is an early complex that appears within another rhythm. The rate depends on the underlying rhythm and if it is irregular. The P wave is present and will be inverted either preceding or follow the QRS complex. It's characterized by the PRI being present nice and tight at 0.12, and so is the QRS complex measures at 0.11 or less. Could be less than that. Can be caused by the same factors that causes premature atrial complexes. Do not normally require treatment since most people with the condition are asymptomatic. Possible causes could be perceived skipped beats, lightheadedness, dizziness, other signs of decreased cardiac output with frequent PJCs, premature junctional complexes. Frequent PJCs may be a predictor of future cardiac dysrhythmias, so look out for what can happen in the future. Our junctional escape rhythm occurs within the SA node, does not function, and the AV junction takes over as the pacemaker. Also called junctional rhythm, a rate of 40 to 60 beats per minute, usually regular within the rhythm with little variation between the R intervals. P waves are inverted and present before the QRS, and the PRI is less than 0.12 seconds. QRS is nice and tight at 0.11 or less as well. Often accompanies SA node diseases. Increased vagal tones are valvular heart disease, inferior wall myocardial infarction, and other conditions. It can occur after resuscitation from cardiac arrest, and treatments depend on underlying causes that may require surgically implanted pacemakers. In the field, atropine should be considered, and transcutaneous pacing may be necessary if the patient's condition is severely compromised. So this is Simple way to do it is multiply by 6. 1, 2, 3, 4, 24. That is a very slow rhythm. 300, 150, 100, 75, 60, 50? 50. Yeah, alright. Accelerated junctional rhythm is present with rates exceeding 60 beats per minute but less than 100 beats per minute. So this is like a sweet spot basically. It's not all the way to tachycardia yet, not accelerated, not junctional tachycardia, but it is accelerating to that point. It's characterized by a PRI that is less than 0.12 seconds. QRS could be 0.11 or less, nice and tight. Could be associated with digoxin toxicity. Most common cause is digoxin. You could have an inferior wall MI, rheumatic fever, electrolyte imbalances, inferior wall myocardial infarction, I said that, and the patient could usually be asymptomatic. Junctional tachycardia is accompanied with a rate that exceeds 100 beats per minute. We made it. We accelerated to past 100. The rhythm is regular with a little variations between the RR intervals, and the EKG characteristics are the same as an accelerated junctional rhythm, but the rate is faster. It is uncommon in adults, but also associated with acute coronary syndrome and heart failure. Theophylline is administration or digoxin toxicity. Seldom requires treatment in the pre-hospital setting if the rate exceeds 150 beats per minute and our cardiac output could suffer. At a rapid ventricular rate, distinguished from junctional tachycardia from other narrow QRS tachycardias, is often difficult. It's hard to differentiate these two. If the patient is symptomatic, then they are treated in accordance with the tachycardia rhythm. Now we're to our third wave, third protection of pacemaker before the heart stops. We are now at the ventricles. The ventricles may start originating their own impulses and become the pacemaker if the AV junction and the SA node do not initiate an impulse. They will have a wide QRS complex, 0.12 seconds or more, and there's missing P waves. There's no longer any firing happening within the atrium. Our premature ventricular complexes, they do not have dysrhythmia, but rather early complexes that appear within another rhythm. It is characterized by the lack of P wave and no PRI. The QRS complex is associated with the PVC measures of 0.12 seconds or more. A full compensatory pause will usually follow PVC to determine if one is present. Measurement of the RR interval and underlying rhythm. We want to next measure the R wave of the QRS complex before the PVC to the R wave of the QRS complex after the PVC. A full compensatory pause has occurred if the RR interval that includes the PVC measures twice of that of the underlying rhythm. This is our premature ventricular complex. There's no P wave here. This is the T wave from this complex. So it starts here. Compensatory pause. Nothing's happening. Now we go back in. A PVC may be a unifocal or multifocal. Unifocal means it originates from the same area or focuses within the ventricle and looks like the ECG. Multifocal varied appearances has a varied appearance, more than one that focuses on the ventricular impulses. Okay, let's go back. Oh shit. What did I do? Don't do that. Okay, we're back. So unifocal and multifocal. So yeah, this one looks the same. There's one. Boom and boom. I mean, there's two by Gemini, but you could tell that it's identified. It has a fingerprint. This is what it looks like. Multifocal. So you got one here that's weird. You got one here that's weird. This one doesn't look like this one because it dips down further with depression. This one is green. So we have it looks like this one could be, nope, because this one dips even lower. So we have multifocal, there's different things happening, different firing within different portions of the ventricles. A ventricular couplet is two PVCs with no intervening pause. A run of ventricular tachycardia is a term for 3 or more PVCs in a row that is also referred to as salvos or bursts. Ventricular bigeminy is the pattern that occurs when complexes become so frequent that they begin to alternate with normal complexes.